Yeah, it's okay. Yes.
So good afternoon, everybody. Welcome to the first AIOC midterm conference. Today we have refractive surgery free papers. 4 papers were supposed to be presented, but I think 2 authors are here. So if anybody comes before we close, then we can allow them. And I welcome my colleagues Dr. Chitra Ramamurthy and Dr. Krishna Prasad Kudlu, myself Dr. Rajshekar. So for the benefit of the participants, the time allotted per presentation is 5 minutes. And then so we will be assessing you on 4 parameters. You know the parameters on which we will assess? So we will be assessing you based on the content, presentation, the kind of slides you have made and the originality of the total this thing. So if you are ready, we can start now.
Yes, sir. Yes, sir.
So timer, somebody is looking after the timer?
Yes, sir. Yes, sir. Yes, sir.
So we can start the time now? Yeah, carry on. Come. Dr. Sonam, come. He's the first presenter, so we can start. Wait, I'll pull up another chair. Wait.
One more chair. Ek aur chair le lo yaar. It will come on the way.
So we are 4 judges. One more judge may not be able to join us. So 4 of us will be judging and then we will be submitting the results. So your time starts now. Huh?
Okay, sir. Shall I start, sir? Good afternoon. I am presenting a case of toxic anterior segment syndrome following IPCL implantation in a myopic eye. Toxic anterior segment syndrome is a rare condition characterized by post-operative inflammation after uneventful anterior segment surgery that occurs within the first 12 to 48 hours after surgery. Several etiologies including retained lens material, viscosurgical devices, glove, talc, intracameral antibiotics and endotoxin contamination of balanced salt solution have been identified. So coming to the case report, this was a 27-year-old male patient who underwent IPCL implantation in left eye for high myopia. He presented with complaints of diminution of vision, redness and mild pain 4 days following surgery. Surgery was uneventful and patient had vision of 20/30 on post-operative day 1. Ocular examination, on the examination visual acuity was 20/600 and anterior segment examination under slit lamp biomicroscopy showed corneal edema with anterior chamber cells and flare, dilated pupil with pupillary membrane and hypopyon. Intraocular pressure was elevated on applanation tonometry and B-scan ultrasonography showed moderate echoes suggestive of inflammation. Patient was started on topical antibiotics and anti-glaucoma medications. He was given intravitreal antibiotic 1 dose, that is vancomycin with ceftazidime, under topical anesthesia, and AC tap was done in the same sitting. The AC tap did not show any microorganisms in gram stain and in culture after 48 hours. So following this, the patient was started on topical and oral steroids along with the topical antibiotics and anti-glaucoma medications. So this was the post-operative day 1 following IVIB injection after starting the steroids, and this is the post-operative day 3. You can see the decrease in the edema and the inflammation. On follow-up, the corneal edema reduced, the anterior chamber reaction decreased along with the intraocular pressure. B-scan ultrasonography also showed resolution of the echoes and the vision improved to 20/30. So in 2014, Gomez, Baster et al. Retrospectively reviewed 349 eyes of 216 patients with ICL implantation, reporting low incidences of post-operative complications with only 1 eye presenting with TAS. Few reports of TAS after phakic IOL have been published. Most of them are from anterior chamber phakic IOL cases and only 1 case reported following ICL. So these are the various causes noticed by Bodnar Z et al. There are different causes causing TAS like inadequate flushing of the cannulated instruments, use of reusable cannulas, inadequate manual cleaning of instruments, touching of the IOL or patient contact areas of instruments with gloved hands, etc. So in conclusion, TAS is a rare complication after phakic IOL implantation. Early diagnosis and management is essential to prevent long-term sequelae. The most important step is prevention with adequate intraoperative manipulation of the ICL, surgical instruments and intracameral fluids. These are my references.
Dr. Niranjan, when did this happen? During which period? Time period?
This was actually last year during June, July, sir.
But it did happen only to that case, or there was a...
No, ma'am. It was only It was only for that case, ma'am.
There was anything different surgically you all could have done?
We believe it was probably due to the retained viscoelastic material because there were other surgeries also on that same day. all there were cataract surgeries, but none of those patients had any symptoms. Only this patient had, and there was adequate washing of instruments, adequate hygiene was maintained. So probably it was due to retained viscoelastic material.
No, TAS is in.
This TAS,
Yes.
and which is
No, no, he said that on the B scan on day one.
B-scan, he said, what
Yes.
did you see in this?
Yes, so there was moderate air quality.
Some mild spilling of the anti-aging
Yes.
reaction into the posterior.
Very rare with faking.
Very rare.
Faking it is literally impossible unless some loose zone use.
No, no.
No, inflammatory.
Some little spillover of inflammation can happen. Mild uveitis can rarely happen.
That's not moderate. Day one.
Okay, thank you.
Thank you, ma'am. Thank you, sir.
Niranjan. So next, second presenter. So I call upon Dr. Sonali Prasad. Is Dr. Devendra Bharti here? Devanand Bharti? No, no. So we are having here the third one, no? Sonali. Sonali Prasad. She would be presenting a case on perioperative anxiety and pain in patients undergoing sequential LASIK surgery, comparing fellow eyes. What is that sequential this thing?
So one after the other, like first eye operated and then second eye operated in the same sitting, and then we are comparing the two eyes, which eye had more perception and which eye the patient had more anxiety.
Between the two eyes itself.
Between the two eyes.
During the same surgery
During
setting.
the same session, one eye and the other eye, and then we are comparing which eye had more.
Present your case then.
Yeah, go ahead. Ma'am.
Sorry for the delay, ma'am. My topic is perioperative anxiety and pain in patients undergoing sequential LASIK surgery, comparison of the fellow eyes. As we know, refractive surgery techniques have evolved circumferentially over the past several years. With the abandonment of RK surgeries and the burst of PRK surgeries, it was soon eclipsed by the introduction of LASIK surgeries. LASIK became the mainstay because of the advantage of intact central epithelium. Still, despite the safety and advancement, patients do complain of pain and anxiety during the procedure. The study was reviewed by the Institutional Board Review, and particular consent was taken for the LASIK patient to participate in the surgery, also the participation in the study. The aim of the study was to analyze the patient's perception in consecutive eye undergoing LASIK surgery. The study design was a cross-sectional non-interventional observational study, and it took place between 2020 April, March 21 at a tertiary care center in central India. This was a patient performer where we enter the data of all the patient's basic details and the UCVA, BCVA. Along with that, a refraction, pachymetry, anterior and posterior segment findings were noted. The anxiety score was measured with the standard Amsterdam pre-operative anxiety and informative scale, which consisted of 6 questions. 3 were for the anesthesia anxiety and 3 were for the surgery anxiety. This is a standard scale that is used for the anxiety. For the pain, we used a visual analog scale for grading from 0 to 10. The score in the APIS for the anxiety was divided into 2. The sum of anesthesia was said at sum A and sum of surgery was said at sum C. Sum C was sum A plus sum S. This pre-operative anxiety was completed in the patient in the waiting room, and the post-operative pain was analyzed in the recovery room. Both were orally administered by a trained investigator. Along with that, we also measured the systolic BP, diastolic BP with the heart rate of the person. A complete ophthalmological evaluation was done before the operation. Both the eyes were operated on a sequential basis, and it was randomized into 2 groups. Group A, in which the right eye was operated first, and Group B, in which the left eye operated first. And it was operated by the same surgeon. The statistical analysis was used by the SPSS software version 13.0. And the results came that the study enrolled almost 101 patients, with Group A right eye operated first with 56, and Group B had 45 patients with left eye operated first. Female were the more predominant people in our study group. But despite the Group A in which right eye was operated, or in Group B in which the left eye operated, irrespective of that, the pain in the second eye was more compared to the first eye. And the patient also complained pain more during the suction and the speculum positioning. It was of mild intensity and dull in character. As we can see in the figure, in Group A, in which the right eye was operated first and the left eye was operated second, the pain score was 2 to 5 in the range. And likewise in the Group B, in which the right eye was operated first and the left eye was operated first and the right eye was operated second, in this also the pain score was more. The anxiety score was documented at sum A, S, and C. The two were mostly comparable and insignificant in comparison. There was a slight change in the systolic BP in both comparing the second eye versus first eye, but there was no difference between the diastolic BP. Along with that, we also measured the other parameters and documented in a tabular form like pain, age, pachymetry, spherical equivalence, BP, and pulse of the patient, along with anterior segment, and which was documented but did not show any significant association. In discussion, the LASIK is the current refractive technique aiming to provide a perfect vision. The advancement of keratome has increased the safety profile, but despite that, the pain perception and tactile stimulations are well experienced by the patients. The causes of pain during LASIK surgery can be during eyelid manipulation, where during placement of a lid speculum, a stretching of the orbicularis muscles can be there. Along with that, a suction ring can also lead to an increase in IOP, leading to pain. Microkeratome cuts and laser ablation can cause sensitization of corneal nerves. With that, in our study, the pain score were not correlated with the cooperation score, and increased sensitization to environmental factors were mostly seen. The patients mostly with type A personality or highly anxious and highly irritable patients had more pain in the second eye versus the first eye. These were the El Rami et al. Had documented the pain in second eye more than the first eye, and in a LASIK study where they also showed unclear reason for this and showed more of a psychological explanation or regional stimulation. This was another study where the preoperative pain profile was studied in different stages of bilateral LASIK. In this, they commented that there was more pain during the eyelid manipulation, and small papillary fissures were mostly, complained of more pain. And they advised for a supplementary anesthesia in these patients. Then there was another which was done in the cataract surgery group, where they documented 3 theories for it: physiological, psychological, and pharmacological. Physiological can be because of the nociceptive advancement of the neural heads. Psychological can be because of the anxiety of the patients, because of the personality, and the pharmacological was not justified in the LASIK patients. Then another in PRK also showed no association. The limitation of our study is a paucity of data due to the limited questionnaire, and the VAS and the APIS was not, it was only included in the immediate post-op period. There could be an yes sir. There could be an inter-subject variability, and high pain score was seen in the female patients due to a biased gender. So the road ahead is an individualized pain score can help us in assessing the second eye, and proper anesthesia can be given. And the role of anti-anxiety and local anesthesia can be studied in future studies. Thank you.
Thank you, Dr. Sonali. What's the inference from your study?
So the inference, if the patient in the first setting, we see that the first eye has more pain, we can prepare the patient for the second eye. We can actually have more anesthetic measurements taken for the patient, and we can actually have distractive measures like the playment of a music or talking to the person can also help in decreasing the anxiety level of the patient in the second eye operation.
Pain and anxiety.
So you inferred that the second eye was always more painful than the first procedure?
Yes, sir. Yes, sir.
So any special inference that you could draw, any specific reason which was tied to this?
So mostly 3 theories that is associated with these kind of patients. First is a physiological, because of the nociceptive stimulation of the nerve endings, which was not, which
that was the cataract study that
yes,
you
sir. But
so
the same
cataract was not done sequentially, right?
yeah,
On the same
it
day.
was done. No, sir. 1 month later, it was
So,
done. It was
yes.
not a sequential surgery, sir.
So those were not sequential surgeries.
Yes, sir.
So you can't exactly correlate
Yes, sir.
them with
Yes,
the
sir.
LASIK surgeries.
Yes, sir. So they also ruled out the physiological and pharmacological, and because pharmacological, they said that during the second eye, the anesthesia that is used, that becomes resistant for the second eye till it comes for the second eye. But that was also not valid for the LASIK surgery, because the amount of local anesthesia we use is very less. So the psychological theory is much more appropriate in these cases, sir. And the reading of nociceptive factors is it is not of our domain, sir. We are not that there's no efficient methods by which we can measure the nociceptive stimulus by which it is causing the pain and anxiety in the patients, in the nerve endings.
So what about anxiety part between the first eye and the second eye?
This anxiety, sir, it was more in the second eye, but the association was insignificant, sir, in our study. But there has been study in other LASIK or PRK patients where they said there was decrease in anxiety, and because the patient was less anxiety, they experienced more pain because they have become very desensitized with the environment, and when suddenly there was a stimulus, they felt more pain.
How objective is the measurements? What do you think is the subjective element in all these things?
Sir, it is, I would say, not very, very relevant if we are talking about the objective measures, because it can be person to person variable. So, if a learned person is taking, he should, or the person should be acquainted with the whole procedure, and mostly the patients that we talk about, they are not very pre-acquainted with the procedure. We do try our level best, but some of them we miss out on.
Thank you. Thank you. Any other question, Chaitra?
Thank you, sir.
So, do you have other presenters here? One Devanand Bharti and Dr. Purandar Basin.
Devanand Bhakti is not here.
Purendra coming for a free paper.
No, पता नहीं वो नाम तो लिख लिया है सर.
रुको, रुको, रुको.
Yes, I think we can close the session. Thank you. Thank you.